I have a unique opportunity from my perspective, being an interventional cardiologist, being in a center for the past 10 years and directing the PERT team. There's only two individuals. It's myself and my co-partner, who's an interventional radiologist. And we sort of have managed these patients from the very beginning, upstream and downstream, which includes both the first onset of phone call from the emergency room to the management in the hospital situation, including longitudinal follow-up. Today, I have the unique opportunity to discuss a very certain subgroup of patients that we all sort of struggle on deciding on which is the best management and option for them. And those are the intermediate low-risk patients. And just to quickly summarize for our viewers, intermediate low-risk individuals is coming from the ESC guidelines in 2019. As you guys know, we have two separate guideline committees. We have the AHA and the ESC guidelines, and most of the information does overlap, but in specifically to define the intermediate low-risk category patients as those folks that have some sort of RV dysfunction and RV injury. So you define RV injury very simply by either cardiac troponin positive or BNP, but typically attributed to cardiac troponin. The RV dysfunction is an interesting sort of category. As a cardiologist who reads echoes and reads all the echoes on all these patients that come in, irrespective if it's already been officially interpreted, which is very important for my interventional cardiology colleagues to look at the echoes. It's important to be able to distinguish what is considered RV dysfunction. Amongst the traditional dogma definition of RV dysfunction, it's 0.9 or greater from RV to LV ratio. However, there's a lot of emerging echocardiographic variables that we should all be paying attention to. And as a cardiologist, it's important for all of us who are on part of the PART team to identify those different variables. At our institution, we have developed a specific PERT protocol in that we look at a number of things, not just the size of the ventricle, but the function. And there are things and aspects such as the PASP, pulmonary artery systolic pressure, greater than the LV stroke volume, which has been duplicated and studied in other clinical trials compared to Bonova and other factors. And that's been actually very correlated to high-risk patients that would be re-stratified. So in other words, when we identify a group of patients that may have RV dysfunction and RV injury, yet have a normal RV size, there are a number of other factors that we should be looking at. So for example, let's take a case series. We have a 58-year-old female who has listed there no prior history of VTE or risk factors, and she presented to our emergency room with a 3-day history of dyspnea. She is normotensive, heart rate's 95, her respiratory is 28, and 90% are room air. So otherwise relatively stable. This was the interpretation from the CTA Nighthawk radiologist, diffuse first order and second order bilateral pulmonary emboli. The echo shows the following findings. And as I'm listing there specifically, we don't have the traditional definition of RV dilation or dysfunction, but we have RV another emerging factor, which is the TAPSE, and we have no evidence of RV injury in this particular patient. It is in my sort of clinical practice that I manage these patients initially, like all of us do, with anticoagulation. I reevaluate them the day later. The guidelines support that, and we should be thinking about anticoagulation always initially, and it's not wrong to reevaluate the next day to decide again on what may be the next treatment category for them. I like to call it the road test. So we often have our patients walk into the hallway for a brief period of time while we simultaneously manage and measure their blood pressure and their oxygen levels. And in this particular patient, I reevaluated her about 18 hours later, which was the next morning. And she had a brief episode of hypoxemia, tachycardia, and a feeling of near syncope. So in this group of patient, this is what we would consider intermediate low risk. My next algorithm would be to further risk stratify, and that would be, in my opinion, doing a hemodynamic invasive catheterization. Now, certainly we could also replicate this by doing an echo. You can calculate the cardiac index and cardiac output relatively easily at bedside as well. But as you notice here, right heart catheterization tells us that there is a lot more happening in this particular patient than what meets the eye. So a cardiac index of 2.0, a mean pulmonary artery pressure of 33. In this particular patient who had proximal thrombus, which is another risk stratifying opportunity to look at these patients' CT prior to, I went ahead and proceeded to perform thrombectomy. Now, some folks may argue and say, well, in this particular subset of patients, what's the data that supports mechanical thrombectomy? And that's also very true. The data we have is actually in a registry, in our FLASH registry of the first 500 patients studied. 36 of them, which are comprised about 7.2% of those patient population, actually fit into this very same definition, the intermediate low risk category. And again, defined by RV dysfunction or some form of RV injury, one or the other. And what was very interesting on statistics, the pre-cardiac index, the mean was 1.54, and the post was 1.98. So an improvement, about 27% improvement in cardiac index immediately on the table. And many of those patients had a mean PA pressure of 28, which was the mean, that reduced to 22, which was a reduction of 22%. So similar to what we have in this particular patient, a mean PA pressure of 33, a cardiac index that is on the lower end, and an immediate reduction of mean PA pressure of 26. Now, I don't typically re-evaluate the cardiac index immediately after the particular procedure, but once I get an adequate removal of thrombus, have hemodynamic criteria to confirm, and now my practice has been also to follow not only angiographically, but to use IVUS, I stop at this point and now transition the patient to the ambulatory setting. Now, what have we noticed and what we can learn from this particular group of category of patients? I think first and foremost, the arbitrary evaluation or dogma of just looking at the RV-LV ratio of 0.9 or greater is going to shortchange our evaluation for many of these patients. There are lots of echocardiographic criteria that are emerging. There are lots of even hemodynamic catheterization opportunities to further risk stratify these people. And so, yes, perhaps first and foremost, anticoagulation in that first line of therapy, but the day later should be reevaluated and we should risk stratify that particular patient. And when you're on the fence and you don't feel comfortable, a hemodynamic catheterization or even an echo criteria to evaluate the hemodynamics can help guide your next decision making.